emergency medicine, you have to be like an ER doctor plus. So that, there's ER docs that are great at ultrasound or ER docs that are trauma specialists. And I thought, what's my plus going to be? What's my niche going to be? And then I thought I can see how burnout's going to happen here. And so I need to do something that is just going to make my career more interesting or me more marketable, but to increase some career longevity.
Welcome to How I Doctor, where we're bringing joy back to medicine. My guest today is Dr. John Dayton, emergency physician at Intermountain Health, Stanford Emergency Medicine faculty, and co-founder of a new healthcare seed fund called Wildfire Partners. Full disclosure up front, John's also an advisor to Off-Call. John has one of the more unusual trajectories in our field. He spent years doing locums on Navajo and Hopi reservations throughout the Indian Health Service. He became Stanford's first medical design and innovation fellow. He picked up an MBA at Hopkins, and now he's writing checks to physician-led healthcare startups, armed with a finding from a paper he co-authored that more than a quarter of healthcare companies that crossed the billion-dollar valuation in the last decade had at least one clinician co-founder, which cuts pretty hard against the trope that doctors are just bad at business. So today I want to dig into that. What does it actually take for a physician-built company to survive contact with a real hospital or health system? I want to ask him how he stays as humble and generous and kind as John Dayton truly is. I'll be back with John after a quick word from our sponsors. Before we jump into the episode, I want to thank our sponsor, Evidently. Evidently is the clinical data intelligence platform built to help physicians harness the ocean of patient data they're drowning in every day. From chart summarization to AI-assisted note drafting and denial appeal support, Evidently makes sure the right data shows up at the right time. Physicians using Evidently report spending less time hunting through charts and more time focusing on patient care. That's why they've become a trusted partner to health systems looking to improve documentation, quality, and revenue sustainability. The company is led by providers and AI researchers that are dedicated to reducing documentation burden and helping clinicians practice at the top of their license. If you want to see what Evidently can do for your hospital or your practice, reach out today at www.evidently.com. Now, let's get into today's episode. Before we jump into the episode, I want to thank our newest How I Doctor sponsor, Savaro. Savaro is a top telestroke and neurology company that was built to fix one of the most predictable failures in modern medicine, getting timely, consistent access to a neurologist when you actually need one. Their team of board-certified neurologists deliver rapid video response, clear decision-making support, and continuity from the first exam all the way through treatment planning and management. Hospitals working with Savaro see faster door-to-needle times, fewer transfers, and measurable improvements in patient outcomes. And because Savaro was built by physicians, the workflows actually match real-world medicine. If you need stronger, faster, and more predictable neurology coverage, visit Savaro.com to learn more. And now, let's get into today's episode. John Dayton, welcome to How I Doctor.
Thanks for having me. What a privilege to get to hang out with you.
Maybe give me what's the core thesis of the fund?
Yeah, like you were alluding to at the intro, I am real bullish on companies that have physician founders, physician advisors, because I feel like they understand the space. When you work clinically, you understand pain points, you understand what you need to help patients, but you also understand what you need to improve your workflow and what you do during your day, and physicians bring unique insight to that. So we have a $5 million fund. We've raised over half of that, and we're going to focus not just on companies that have physician founders, but companies looking at the way AI is changing our clinical workflow. We're really focused on digital health companies and devices, particularly like smart medical devices. That's kind of our area of sweet spot. Part of it is because of the sea change, with AI disrupting everything. But there are a lot of other things happening with how we're billing for care, how we're being reimbursed, how people are seeking out care, and how physicians are connecting with their patients. And so we look at companies that address those areas as well.
Well, even just, I'd imagine if you're starting a company, your cost structure is different. How are you going to spend the capital that you maybe raise from Wildfire Partners is different. Like maybe you have one engineer and they're running 12 sub-agents from generative AI, as opposed to 3-5 years ago, if you're raising $1 million, who knows? Is half of that going, or two-thirds or three-quarters going to just engineering talent to build the thing?
It's a great point, and I'm still a big believer in strong teams, but I think a lot of the tech you needed to supply at that time has decreased. I think back to when I built a medical education company back in the mid 2010s, and we spent the majority of the first year just trying to figure out, all right, well, I've got an idea for this website that I want to build so that physicians can look at different education resources and share them with each other and kind of get a crowdsourced feel. And I look at what we built and think, "Gosh, I probably could have vibe coded that in like a weekend now with the current tools." And I'd still want a strong dev team. I'd still want a strong engineer, but I'm probably not going to spend as much money to get there. And so not only has that made the barrier to market entry a lot lower, but it's made it a lot easier for a physician to say, "Hey, I've got an idea."
About 25% of healthcare unicorns have at least one clinician co-founder. I wonder how that looks today with generative AI as well. I mean, everybody can be a co-founder now because there are companies that are just one or two people. Harder in the health tech space, I think, but still, there are lots of companies these days that could just be a marketing agency that's one guy plus a designer plus Claude or something like that.
With our fund, the thesis that we looked at is where my background is helping companies do effective pilots and regulatory strategy. I wanted to partner with someone who's really good at building companies. So I partnered with a longtime operator because not only did he work in the telehealth space and RPM, but he was an entrepreneur in residence for Startup Health. So he helped scale a lot of companies from early on to exits. And so I still think you need that core team, but we're doing this with our, just the two of us and an amazing intern from Brigham Young University. And, obviously it's a first fund and our team will get bigger as we move along. But right now, a lot of the things, we're not going to have an in-house legal counsel because you can outsource a lot of that. Or, you look at like back office things like, where we're going to work and how are we going to structure, our contracts. And a lot of that is, you can hire that as well. So it's really interesting. We can do it with fewer people and we can really focus on the companies and finding great healthcare solutions.
You've practiced emergency medicine a lot of places. Have you learned things from doing that work and having a diverse clinical practice that you think has been giving you a leg up or taught you things about business or life or the world from practicing at both less resourced environments and then the Stanford mothership, which has every test and every specialist that exists in God's green earth?
Been able to work in a lot of different environments, which is uh, been a huge blessing for my life. But you definitely have different problems on the Navajo reservation where I worked during peak COVID, and we didn't even have beds to admit to for part of it. There were maybe 3 or 4 beds. They were filled up very quickly. No OR was available. We had very limited options as far as especially consultations. At one point, I was told I could no longer drain peritonsillar abscesses because if anything went wrong, not only did I not have an ENT available, I didn't have an OR available. And so that's very different than when you're at Stanford and you go to admit a patient and the problem there isn't do we have the right person? It's like which cardiology group.
It's a different problem at Stanford, yeah.
And so yeah, on a resource poor environment, you're thinking, all right, but how can we democratize this healthcare? What's a cheap solution that can make a big impact when you have a resource poor environment? At the same time, when you work at a place like Stanford, you think, oh, here are some great tools. How can we get this out to our colleagues? What makes the most sense? And what can be shared with other institutions? And so yeah, it's a different set. I think one of the biggest things for me, and I'm sure you appreciate this as well, is emergency doctors. We have the highest burnout rate. We always hear about it, in the Medscape annual survey, and we always see some of our colleagues have, different struggles with that. And so I thought early on, in emergency medicine, you have to be like an ER doctor plus. So that, there's ER docs that are great at ultrasound, or ER docs that are trauma specialists. And I thought, what's my plus going to be? What's my niche going to be? And I was lucky early enough to practice in my career with a couple physicians that brought products to market, and I was fascinated with how they did that. And I set up the Utah Society of Physician Entrepreneurs, and we'd have pitch events, and we'd have these doctors tell their stories, and a lot of that led to opportunities for some advisory work and meeting with the local angel investors and venture capitalists and tech transfer folks, and And so that became like kind of a fun second network and to work with those guys. And so during COVID, I mean, I loved working on the reservation, but it's a bit of a grind. I'd leave Salt Lake City, I'd drive 8 hours, go down to Chinle, Arizona. I'd do a bunch of night shifts in a row, and then I'd drive home, and then I'd try to, catch up on my sleep and binge parent and, do everything, that my very patient wife had left on my to-do list that I'd pushed off for a week and a half, and then I do it again, and I thought, "I can see how burnout's gonna happen here," and so I need to do something that is just gonna make my career more interesting or me more marketable, but to increase some career longevity.
John, I want to go back to one thing you said about, being an emergency physician plus. I guess it made me think like, oh, is this a nature or a nurture thing? I thought of the ER doctors work shifts. And so we tend to have random Tuesdays off during the day because we're maybe on nights or swing shifts or something like that. So you can kind of cheat and you can do one thing during the day and then you go into work and work 3 to midnight and whatever, turn around that way. Is it the shifts allow us to have another interest, or is it the work is so stressful and draining and straining that we need to have another outlet because it's too challenging to do full time?
I think it's a bit of both. I think we choose this because we like going from room to room and putting out fires and fixing things we can fix that day, and that's just kind of how we're wired.
A quick word about today's sponsor, Evidently. Their platform turns an ocean of fragmented clinical data into concise, actionable insights. Chart summaries, note drafting, denial appeal support, HCC capture, so you spend time caring, not chasing. A transplant surgeon at a large academic medical center recently took transplant referral review from 2 hours to 20 minutes with AI-assisted chart review from Evidently. Physicians deserve workflows that improve accuracy, reduce exhausting chart biopsy, and help us practice at the top of our license. If you want to see how this might work in your hospital or your department, go to evidently.com. That's evidently.com to get started today. I want to take a moment to thank our sponsor, Savaro. If you've ever waited and waited for a neurologist to call you back, you know the problem that Savaro was built to fix. Savaro is a physician-led telestroke and neurology company that delivers rapid virtual neurology coverage that's reliable. Their board-certified neurologists connect by video in under 45 seconds, and they stay with you through the entire decision-making journey. Hospitals working with Savaro report faster door-to-needle times, fewer unnecessary transfers, and measurable improvements in patient outcomes. If your hospital needs stronger, faster, more consistent neurology coverage, visit Savaro.com to learn more. John, you talk about the 4 Ps. I think it's property, pilots, I'm cheating, publications, product clearance. And you've laid them out on stage and in print. Maybe just tell the audience about what they are, why they're all P, and then I've got a couple other questions for you.
Yeah, absolutely, absolutely. So, a lot of times if you're reviewing an idea for a new company, you're figuring out, all right, is this company going to work? And people have different templates that they use, and for most companies, you're looking at things like, is this the right team? Is this the right timing? Is this the right technology? Healthcare is a little bit interesting. It's a little bit more complex, and so I tried to create this mnemonic so that I'd be able to you know provide a way to evaluate as a physician, like, oh, does this company have these? And if they don't, I can provide some advisory work. Or if I'm looking at funding this, do they have all of these? And if they don't, I need to talk with them about, something that they're missing or how they're going to do it or how they're going to move forward. So the first one is products. What's their market solution? Have they built something? Is there a big enough need for it? Is it going to do well? The second one is property. Do they have intellectual property? We talked about lower barrier to entry. And so this is one of the areas where you can create a moat and make it difficult. If you have intellectual property, particularly on the regulatory pathway, that's a really strong signal. The other reason that's important is because a lot of early companies, they'll come and they say, here's how much money we have in the bank, here's how much money we're raising, here's what we're trying to do. And you realize, boy, they don't have enough for their FDA clearance for this 510 that they want to do.
Because you just know it's going to cost you this much time and money to do.
Yeah,
Yeah.
huge component to that. And that leads to the third one, which is product clearance, and that has to do with their regulatory strategy. Which do they need to go through the FDA? If they do, which pathway do they need to use? Once they've done that, what are the steps for them getting CMS clearance? Have they been able to show that you know, their solution is cheaper and that it's working in areas? And can they get a regional approval or a national approval? And then the biggest one for all of these is payment. You hate to cut it down to that and be you know, sound that capitalist, but at the same time, if you don't have revenue for what you're doing, you don't have a business either. And so this is really important on who are their early customers and what are they paying? And is this something that is expandable? And then you touched on this as well, but the fifth one is pilots. And this goes back to when you're selling to a healthcare system, you got to speak several languages. You you have to make sure you know the mission for the group you're selling to because that's how you get the CEO on board. Does your solution align with their hospital's mission? The next one you have to think about is the CFO, and that's where we go back to payment. Is there a reimbursement pathway? Is this something that enhances one of their product lines? And then pilots are huge where it comes to us as physicians because we're the next step. Because if you don't have a physician evangelist for what you're doing, then you're not going to, the hospital system may buy you, but no one's going to use it. And so the trick is pilots is how we speak to each other. This is our signal. Evidence-based medicine, this works, this is effective, and that's how you move forward. And then along those lines, the sixth one is physician and patient feedback. You know, do the doctors like it? Do the nurses like it? How does the rest of the staff feel about the product? Does it make the office staff's life easier? And does it make care better for the patient? And then the seventh one kind of goes back to the pilots and the feedback, and that's publications. And that's going back to us again as physician founders or physician users. Are they speaking our language? Is there evidence in what they're saying?
You're describing it from, hey, should I consider advising these people, or am I considering, investing in this company? You could almost also use those P's as a way for somebody who maybe has an idea for them to decide themselves, hey, is this a random idea? Is this a good idea, or is this actually a company?
Yeah, absolutely.
Like, it's almost like, hey, I have an idea. Can the idea turn into a product? Can the product turn into a company?
Yeah, how does this go from like a nice to have to something I can build a business around?
Yeah. John, as a physician and an investor, I always like to have people react to just kind of the tension in these different roles. Say you're evaluating a company, you might say for sure that this is going to help the physician or the physician and the patient, but it might not have apparent value to the health system or to another player or stakeholder in the system. How do you think about those? God, I really want to fund this because it'd be so good for doctors and patients, but I don't think the health system cares about this issue at all.
It's a great question, and that's part of the reason I have this template because I feel like you do need to check all these boxes for it to work. At the same time, something that's good for the patients and good for the physicians is almost universally going to be good for the health system. And so,
You would hope,
yeah,
yeah,
there's
yeah, yeah.
congruency there.
I guess it's more. That's a great point. It's the principal agent problem, where it's like the person who's signing the check to buy the, let's say, EHR, the CFO who's signing the check to Epic every month is not the person using the tool that,
Yeah, the end user problem, right?
and the CFO has different metrics and expectations for what they want than what the physician and the patient want necessarily.
Yeah, one area that I was thinking a lot about this morning. Actually, I was just commenting on some LinkedIn posts and reading back. We've had all this hype about ambient scribe technology, and obviously there's a huge need. I don't think there's anybody that's going to tell you that they want more pajama time and they want less time with their patients, and it solves both of those. But some of the initial data is coming out saying, maybe they are not saving that much time, and maybe it's just incremental. And I think part of that's the adoption. But I think the part that's being left out is I think it's a huge solution to physician burnout. And so we may say, like, oh, we're saving 3 minutes here, 5 minutes there. And is that enough to justify it? Really, I think the way to look at that is it costs $1 million for a hospital to replace a physician. And if people are burnt out, because the EHR system is terrible or something else like that. And you're building a solution that keeps people working at your hospital longer, and then they're happier at your hospital. You need to be able to quantify those numbers as well. And so I think that's part of the discussion that should be added. And you have to look at when you're evaluating a company or looking at investing is saying, all right, is this going to be like, is this an incremental thing that's going to kind of make things a little better? Is this going to wholesale change how we do it? Is this going to be revolutionary? And so those are the kind of things to look at when you're figuring out investment decisions or advisory decisions.
Yeah, I would agree, John. I always tell like C-suite leaders, like you can't consider the risk or the benefit of anything, AI, a new CT scanner, a new drug in a vacuum where it's its own thing. You have to consider it in the well, what are all the ways this could benefit or risk my organization? I was talking with an ER doctor friend who said the pharmacy was asking the ER doctors to spend less on IV Tylenol. And from some pharmacy research, they said, oh, well, IV Tylenol costs, you're using too much IV Tylenol, it costs $2 million a year. And the ER doctors came back and said, whoa, 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 you're not considering the other costs in this system. You're looking at the pharmacy costs. I get it, you're a pharmacist, but you're not considering like what's the cost of an ER bed that's taken over for longer because I can't get the patient's pain under control, or what's the cost of a patient who doesn't want to be exposed to opiates for a variety of really good reasons. They were saying, oh well, you could have given all these patients from our records, you could have given more of the patients oral Tylenol. And there was arguments about how fast oral Tylenol works versus IV Tylenol. And then it became kind of an informatics mess of like, yeah, most of the patients who we don't make patients NPO in the ER. So I understand you can look at a patient and from your data, seems like the patient should be able to take oral Tylenol, but a lot of patients in the ER are vomiting. John, let me ask you a little bit about physician founders and what traits you think. Maybe this is the theme of this episode. There are pros and cons to everything. Like, what traits do you think make physicians good founders? And then, what are actually challenges for us that you see when it comes to a physician that's founding a company, whether it's their first or their third?
I, yeah, and that's kind of a tricky question because I was one of
Because we're all perfect, right?
yeah one of like the slacks. There was a big discussion like, oh, are these dropout docs and do we view them negatively because they're not functioning in clinical practice and they're doing other things? And someone saying, no, maybe these are like the most ethical, holistic ones, and they were dealing with burnout as moral injury, and they couldn't practice not up to their ethics.
They want to change the system. Yeah.
Absolutely, and there's too much pushback for that. Or the other way of saying it is, we're just natural problem solvers, and these are people that see like, hey, this is a big thing. I'm going to fix this. And so I like with physician founders, particularly when they're intellectually curious. I like ones that are leaders professionally, as physicians, but also they kind of bring that street cred to solving this. So someone that's gone to in emergency medicine, our specialty society is the American College of Emergency Physicians. We have our annual lobbying conference in DC every year. Like the people that tend to go to that and are already lobbying for change in health policy tend to be the ones that say, "Hey, and this is something that will work really good clinically." And so there are already folks that are interested in making change and figuring out ways to do that, and networking with folks that they're able to do that as well. And so it's really tricky, right? Because you take your best doctors and turn them into something else, and then you don't have those doctors practicing anymore. And so I really like the ones that I know it's a high bar, but have one foot in clinically and one foot in whatever else they're trying to do, because I feel like they're more aware of necessary solutions and things that their patients need, and because they see that. But I feel like the ones that have street cred, the ones that are builders, the ones that are already leaders in what they're doing, I think that translates very well to, hey, I've ran QA for my department for years. You know, figuring out how to run an effective pilot is very similar skill set.
Yeah. John, you've seen a lot of pitches. I can't imagine what your inbox is like with decks that you get sent. What stands out to you as the most important traits for a successful early pitch?
So for an early pitch, I want to know that they've really validated that they're solving a problem. You know, there's the Stanford biodesign curriculum. I'm a big fan of it, having done the biodesign faculty fellowship, but also because it's kind of the clinical leader in the space. That's a free course that anyone can take online. But the first half of it is saying, is this a big enough need to build a business around? Is this a strong enough pain point that people are going to buy your solution? That if you pitch that in and say, well, we're going to build that, and someone would say, boy, I'll buy it right now if you got it. I mean, that's a huge thing.
Uh-huh. Yeah.
And so along those lines, if they validated that it's a need, if they have, pilots that they're already working with, if they have other physicians saying, we love this, we can't do this without it, it saves us time. Things like that are big signals to me. Because in healthcare, you make a lot of money when your solution gets adopted, you know, by a ton of different clinics or offices, but particularly if it gets adopted in a hospital center. So companies are able to show that they're already working within a hospital system, that they're helping the hospital meet their goals, and that a hospital is referring that company to other hospitals. That makes a big difference. That's a huge signal for me.
That's really helpful. Yeah. John, you're such a positive, optimistic person, but I will ask you the opposite question. What's the worst thing a founder, a startup, a company can do during a pitch that maybe turns you off immediately?
There's a couple things that people say that make me think they haven't researched this enough. So if a company ever tells you, "Oh, we're the only one in this space," like that is just categorically impossible. You may be the only one, like, with your particular tech, but there's always adjacent companies that and this is a new, a vertical for them. So that's something that makes me think, maybe needing to research this better. Or if they say, "Oh, we only need this much to get to market," and it's a little too rosy, and I'm thinking in there, "Well, you gotta get a product through FDA clearance, or you gotta get CMS approval to get payment for this, and I don't see where this is on your runway. How strong is the research by what they're saying, and have they validated and looked at this process?" You can kind of tell a lot. Every company is going to give you good projections, and there's always a hockey stick, and it always goes from like negative millions of dollars to 2 billion, by 10 years, and yeah, and everybody has kind of a projection like that. But I'm looking at that to say like, have they really dialed that in, could this be a real path for them? And a lot of the times they'll say something very, when they talk about, their total addressable market and the part that they're going after. If this is reasonable, I feel like, yeah, they've done their homework. They figure out we can get into this space. We can leverage this advantage. We can use our current, you know, um, pilots to get more. And
It almost sounds like you're describing someone who's like, has the right level of confidence as well when they're speaking.
absolutely,
Like, you don't want somebody that's saying, like, oh, this is $1 trillion company and it'll be $1 trillion in 3 years. And you also don't want someone that is yeah, you don't want someone that's too cocky. I think, especially in medicine and healthcare, like you need somebody with some humility
yeah.
about the challenges of healthcare and how serious it is in hopefully what they're presenting and trying to build to help, hopefully helping people's in the list there somewhere. And then, yeah, I guess, in the larger tech world, I think sometimes that personality of like overconfidence is rewarded, but I would think that's probably it's not looked upon as positively in the health tech world because people are like, dude, that's never going to work. Or like, you're crazy if you have no clinical experience and you think whatever, a neurosurgeon's going to immediately just start using a new scalpel or something.
Yeah, there's a little bit of a difference, right? You want that confidence. You want them to feel like they've researched it, they've made a plan, they've looked at things. Like that's a very reassuring confidence. Like to say, my company's going to do X because we've done Y research and we're already taking Z steps. Like that goes a long way. If someone's like, "This is going to be awesome," well, have you talked to any doctors about it? Made sure that's something they. There's no way they don't need this. Everybody needs this. Like that
Yeah.
comes out a lot different than someone that's confident because they put their homework in.
I mean, even just including a slide or stating what you think the challenges or the risks are going to be of
Absolutely, like a
that
headwind
actually
stone.
is
Yeah.
that actually I think is way stronger because it shows that you're not like head in the clouds person. You actually like, hey, this thing is going to be really challenging, but here's how we're going to overcome it. This thing I think won't be an issue for 3 years, and then we'll, like that shows that you've planned ahead and that you really have done your research. I think.
Yeah, that level of research and understanding, goes a long way.
John, let's talk about AI a little bit. Where do you think AI is going to have its biggest impact in healthcare?
I think where AI can be very useful, everyone talks about the clinical support side, clinical decision support. And that's sexy. Like,
Totally.
oh, this AI, beat the students at the USMLE, and there's obviously a lot of critiques of those kind of papers. I think the biggest thing,
Many by me.
well, but I think one of
I'm
the biggest things
hypercritical of benchmarks. Yeah, yeah, yeah.
is AI for operations. You know, we still haven't figured out optimal ways to staff in New York. We haven't figured the optimal ways to do billing and interact with insurance companies. We haven't figured out, the ideal way to make sure different hospital service lines are connecting with each other and patients aren't getting lost. And so, I'm a big fan of AI for operations. Don't get me wrong, I love the clinical decision support. But I think AI operations are really overlooked. The other areas where I'm very interested is as Americans change how they get their health care. And one of the positive things about COVID is people really like getting, not having to leave their house and getting the telehealth component. And I think you can really match having a doctor that oversees care with some coaches, some APPs, an app with reminders, and so I'm really interested in protocol based or specialty based workforce platforms, particularly when they integrate with existing EHRs. And so those are some things I'm pretty bullish about.
Everybody always talks about how it's easier to show your, hockey stick up and to the right concept that you're going to be gaining money and but the other interesting angle that I don't think gets enough attention because it doesn't feel as like sexy or whatever is like reducing costs. We know healthcare costs are extremely high. You could imagine something that I think I don't know. I think CHF is maybe like the number one admission diagnosis. But imagine if you can take the annual healthcare spend of the United States on CHF and drop it from 20% to 19%. That's a whole lot of
Yeah,
money.
and even from the hospital perspective, right? Someone gets readmitted for a recent CHF exacerbation. A lot of times that's not paid. And so, what can hospitals do to prevent those readmissions? How can we harness, our hospital at home platforms? How can we use, remote tools, patient communication, and other like anticipatory tools to avoid those?
I mean, I think it's wild. I've even seen fee for service hospital systems who are really starting to approach problems and questions like value-based care
Yes,
systems because the boarding, the wait times are so atrociously bad that they're like, hey, I realize that I could get paid more money if I admit this chest pain patient who maybe doesn't need to be admitted to the hospital. We've got to find some other solution because if you admit all the chest pain patients, even the sicker ones that maybe pay us even more money are stuck in the ER and are getting sicker.
I think there's two major kind of transitions the way things are getting built, and recognize that companies that are adopting early and doing well. One of those is there's a lot of transition between fee for service and value based care right now. So value based care companies that are thriving right now in a fee for service environment, they're going to crush it when we turn to the value based care reimbursement. The other one that I think is important, it's kind of an ethical imperative right now to recognize you know determinations of health and address those as well. Right now, it's the right thing to do, but that's going to be codified, and that's going to be the way things are built in the future as well. So companies that are recognizing early on, like this patient's going to have trouble picking up their meds, or this is going to be a rough transition from ER to home, or this is going to be a rough transition from inpatient to outpatient care, and what hospital resources can we utilize to keep this patient healthy in their home. I think that's those two types of companies particularly are going to be in really good position as billing and structured payment motivations change.
John, in our last 6 minutes here, something like that, I'm going to ask you to react overrated or underrated to a bunch of hot topics. You ready? Overrated, underrated. Physicians getting an MBA.
I don't want to sound like I'm playing it both ways. I think it's underrated in that the more physician leadership you have in your hospital or in physician-based leadership in companies, I think the better off those are. And we've seen recent literature that shows that. At the same time, I don't think you get an MBA just to get an MBA or just to drop
Just
out
to
of
have
medicine.
the letters after your name.
Yeah.
Yeah. Yeah. Okay. Over, underrated. health system venture arms.
I think they're totally underrated. I love seeing them say, hey, here are our goals for the year. Here's what we're focusing on. We're going to talk to these physicians because they turn out to be great advisors and scouts. I think it aligns the hospital financial and tech leadership. And I think it also integrates a physician voice. So I'm a big fan of that.
Yeah. Over underrated digital health fellowships like Stanford Biodesign.
Oh, I think they're totally underrated. I'm very biased in that answer, but again, this goes back to if you want to increase your technical knowledge and credibility, if you want to increase your options of what you're doing, they're a great way to do that.
Over underrated ambient AI listening tools.
I think it's not even. I think we've recognized that they're great. And like we were saying before, I think that some of the early research is kind of bagging on them, saying it's not worth the short-term benefit. I think the long-term benefit's huge.
Over underrated wearables.
Right now, I'm going to say overrated.
I think so too.
But there's a potential for it to shift. And the reason I say overrated is because there's this great movement and everybody wants to make themselves like a digital twin and hack their lives and DIY. And I think it's awesome. But you have to look at a lot of these tools are not clinically proven
No, they're like health.
to give good results.
They're wellness.
Yeah. And so the reason I say overrated right now is because I don't think a lot of them have the clinical rigor and you can't trade them out one for one. I think if there's a standardization that needs to take place, and then I'd be more on the optimist side.
John, final question in our last 2 minutes here. If your new venture, if Wildfire Partners is successful, what does winning actually look like to you? Not just financially, but what do you think it means for medicine?
If our first fund is successful, and I'm kind of playing long-term strategy, that'll make it easier for me to raise the second fund, not just because I'll be able to say, hey, look at these great companies and how well they've done, but it also brings a voice to say, hey, this is a company like, Scrub was the first one in this space to say, listen to the physician voice and the physician founders, particularly the ones that are focused on their patient care improvement. And it's a nice early signal when you have physicians building and validating these products that the next round is going to be useful. But that's a great way of saying, hey, this strategy of listening to the physicians not only like paid financial dividends, but we improve patient care, we improve physician practice longevity. That's kind of how I view that.
Dr. John Dayton, always a pleasure to get to talk with you. John, how can folks connect with you and with Wildfire?
Oh, actually, yeah, thank you. I'm pretty active on LinkedIn. If you want to look for me there, and our website for Wildfire is wildfirepartners.vc. If anybody wants to learn about them, we're there.
Oh, you got the .vc domains. Amazing. John, always a pleasure. It's great to see you.
Thanks for your time, buddy.
Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.